you can really help, and that girl, I mean, I just, that, girl, although she may be like, because her mother would get her married, no, whatever, but I mean, it is that the girls ultimately, we keep craving for boys, but ultimately the girls look after their mothers and parents so well. So please, always welcome the girls for that matter. So it's really, I mean, many, at least 4 or 5 cases I have done that, man. So they have done. Not always. I mean, if the renal failure is because of something else, then of course don't expect. So this is also in same way in this case also. Okay, so same like you do. So good history taking again is very, very crucial. And what we can do for this patient, after the urodynamic will tell you the pattern, and if there is a voiding dysfunction, if there is a like detrusor underactive basically, so there we can try to make it little bit more active, but usually the drugs are not that effective. Like, we used to give certain drugs to they can stimulate the bladder contraction, but the efficacy is not that good. But I mean, the drugs and treatment for incontinence is very good, but for voiding dysfunction is not that good actually. And many times it's better to refer these patients to urologist, to special interest and all. Even I don't treat them that well and all. And similarly, some patients are doing dilatation of urethra. I mean, I have poor experience of that. I don't know what, madam, do you do routinely urethral dilatation? Yeah, in some patients, but in olden times, like patient used to have, especially males used to have urethral constriction because of gonorrhea. So then they would repeated dilatation would be there. But in this case, I have seen sometimes the dilatation makes urethra even more constricted actually by fibrosis and all. So it's a double-edged weapon. So I mean, you have to start it with a pinch of salt and in like after careful scrutiny only. Yeah. Yeah. So but sometimes, of course, if it is so constricted, that may be the only hope for them. So, but that then you do it with the help of the urologist only, always. So that is when the urethral dilatation one can be done, and you can stimulate the bladder with certain drugs, which stimulate it, and then really sphincterotomy has been described in literature, but I have personally never done one. But that is like if you find the like this I mean, sphincter so tight that patient is unable to pass urine, rest everything is fine. So sometimes then we can try to dilate the sphincter, even sphincterotomy has been tried. But after that patient will become incontinent, like urinary incontinent, but that is better than like patient becoming unable to pass urine. And or urethral catheterization, intermittent, self-intermittent catheterization, clean CIS we call it has been described for these patients. That means patient herself we reach her and she has to pass through, but she has to be careful about UTI, because repeated catheterization by herself, and how many patients of us like in Indian condition, maybe in UK when patients are intelligent, but our Indian patient invariably they will have infection. Like my father-in-law, he was a retired ophthalmologist and he was on catheter and all, then he urine used to become muddy, pyelonephritis. So 3-4 times we had to admit him in AMJ and give IV antibiotics and all. So it's important. And then after every, so what we used to do in his case, every 3 weeks we would change the silicone catheter if someone is on the catheter all the time. So whenever I would change the catheter, man, I would give him phosphomycin 3.5 grams sachet of phosphomycin would give, or you give some antibiotic, so that would make him better. But if the patient has got pyelonephritis, then you have to give IV antibiotics to these patients. So that is important. So catheterization, repeat and all, and of course other like behavioral changes, medical, surgical may work in some of the patient, and history taking of course is very, very important. Okay, so that we have done, yeah. Uh, Hmm. So this sphincterotomy, I was telling that rarely, if the bladder, the sphincter does not open at all, it's so tight and all, in that case you can do sphincterotomy. The urologist usually do it. So they just cut the sphincter, but then the patient will become incontinent. So for that, I mean, we had to help her, but it is better that at least you will not lose her kidneys because of that. And very, very rarely the last resort is that diversion techniques. So sometimes they make the bladder this thing, using ileal loops, etc. But they are only just as a last resort, and as gynecologist, I mean, we don't normally do them, we don't see them, but they are rarely used for like radiation cystitis patient, and very rarely the it has to be diversion techniques have to be done. That means the ureter have to be implanted somewhere, maybe in the bowel, etc. Those are the last resorts as a whole. So yes, yes, just like in urine, absolutely, madam. After cystectomy, like after even surgery for bladder cancer, then they do the cystectomy. So then they automatically they will put it in the either they create a new conduit or in, yes, madam. But those are very, I mean, the techniques are difficult, and patient have invariably UTI from that, and also they are only as a last resort. In malignancy, it's okay, still be then. So these are the behavioral conservative treatment, pelvic floor exercises, pelvic floor physiotherapy in some of the patient can be useful. Yeah, botulinum toxin sometimes can be used. So in this case, I think madam might have taught you, told you about it. I was in King's College, with Linda Cardozo and Dudley Robinson. So what they do, they take 1 ml of the botulinum toxins. You do cystoscopy, and there is an injection with that. So you dilute it to 10 ml, and then at 10 places in the bladder we give the botulinum toxins, 1 ml at each side. So that is a very good treatment for very highly resistant type of urge incontinence, and also for these sometimes that can be used. Botulinum toxin can be done. And of course I was telling you, intermittent self catheterization, the gold standard first choice therapy for neurogenic bladder patients when all other symptoms fail. But I mean, many in patients, many will not agree for it, and it's become difficult. So then many time ultimately, some of them ultimately go on the bladder full time catheterization, but then that will of course be an issue. Yeah, these are the percutaneous tibial nerve stimulation, sacral modulation, augmentation cystoplasty. They are the last resort as a whole, and this was sphincterotomy I was telling. So destructive procedure, but after that patient will become completely incontinent, but can be done. And urinary diversion I told you from the urinary bladder. Okay. And if it is non-neurogenic, then of course we have to find out the cause and all. So these are the patients in that case, bladder fibrosis, etc. And if there is prolapse, so you can, in these are the causes. So we can try to treat the cause for that. If there is a urethral valve, we have to treat. So usually we take the help of the urologist for these procedures. And similarly, sometimes the even stone, malignancy, etc. So, but these are the patient I was talking, like gynecological, any exchanging compression, like sometimes fibroid. I have seen patients of one patient of such a big retroperitoneal myoma. It was pressing everything down, and the whole bladder, I mean, uterus was out, and her bladder was just cystosol was so much. I just thought it was papery thin. I just thought it will burst any time, man. So ultimately, we did both combined approach for laparotomy as well as from below, and like we could do the surgery for her, and she became better. So these are the surgical techniques where we can have a role, but usually the most other condition, the urologist has to come and take, we have to take help of the patient. So these are the various like flow meters in this case we can do. So this is the normal curve, and this is the curve for if there is a obstruction element. Yeah, so I won't go into detail of that. Underactive, basically that's same, like it's not contacting well, I told you, so we can give some drugs, but usually don't respond to that much. And underactive bladder, yeah. So usually behavioral intervention, like just like I mean pelvic floor exercise we do, so same way we can do, or ultimately usually many patients require the catheterization or indwelling catheter. And these are the drugs, like, yeah. So parasympathetic drugs can be used for these patients, but the results are not very good actually. And for obstruction, of course, I already said that what we can do, uh, you know, cryurothroscopy or urethral relaxation. I mean, sildenafil, etc. These drugs have been tried, but the results are not very good. But yeah, here this is the bladder neck incision. If there is, I told you that or urethrotomy, just like sphincterotomy, they are there. Urethroplasty, urethrolysis. If there is this can happen sometimes. Like I had a patient of where we put the tape and it was pressing on the urethra. So in that case, like any surgery done by us, like suppose someone did perineuraphy for the patient, so that made the urethra completely blocked. So then the surgical treatment to repair that and to remove that pressure on the urethra can be useful. So that is what we do for urethrolysis, urethroplasty, urethral reconstruction. So if any obstruction is there, we have to treat that, and this can, like successful are good for that, these patients. Removal, excision, section, loosening of the mid-urethral sling has to be done for these patients, because if it is compressing completely, we used it for SUI, but it was made too tight, or it just compressed through the urethra. So you have to cut then the tape. Okay, sometimes it is perforating into the urethra, again we have to cut and all, and invariably there is a fibrosis. So these are the patients which require surgical treatment for that. And urinary retention, of course, all of us know it's common thing. Acute urinary retention is common after cesarean, after hysterectomy, etc. So in this case, usually you do give put a catheter for 72 hours or so, and then, but if it's still there, then you can leave the catheter even for a week or so and give antibiotic anti-inflammatory to the patient, and usually most patients then are able to pass urine after a week or so. It's very rare that they require it for longer than that. But it is the chronic postpartum, again very common. So I think all of us have been dealt with that. So if they are able to no spontaneous micturition within 6 hours after removal of catheter, then we can be there. So it can be like postpartum urinary retention, overt, covert, and persistent. So mostly, I mean, it is usually like the patient has paraurethral injuries after normal delivery, so that can be like forceps delivery, difficult cesarean section. So that can be sometimes impact of the anesthesia also. So usually most of the patient we leave the catheter for initially 72 hours, later for 7 days, and after giving antibiotic, anti-inflammatory good, and usually most patients are able to pass urine. Very rarely that they don't do it, and then you can of course give them yeah, same warm blood training, scanning you have to do any debris etc. And so antibiotic, anti-inflammatory, and if it's indwelling catheter, if the more than yeah, less than 500 in for 24 hours, if it's 500 to 1 liter, then 48 hours, and it's more than 1 liter, then 3 to 5 days at least catheter. That is this thing. So and ultimately we give the trial without catheter initially, but later on usually with catheter. So short term catheterization for few days, long term up to 2 to 3 weeks can also be done. And very rarely some of the patients may require this is the post almost same surgery. So difficult surgery in relation to urethra. Whenever you are doing surgery, I tell my postgraduates, no, they say, sir, more urethrocoel and all. So avoid about at least half to 1 centimeter of the urethra. Avoid surgery in that area, because if you are too close to the urethra, then patient can have voiding dysfunction or this difficult in passing urine. So over distance you have to see. So usually that's what I told you, that most patients will ultimately require management will be voiding and very catheter for initially for 72 hours, later on for up to a week or so, antibiotic, anti-inflammatory, and they are able to pass urine. It's very rare that they will require self-intermittent catheterization or long-term catheterization. If they require, then you need to take the help of the urologist to find out further treatment for them. So thank you very much. Thank you. Any question, please?
Yeah, Dr. Sharma, when you were talking about urethral stricture and all, I hope you remember we referred a case
Yes,
who
ma'am.
had VVF repair by somebody, and whole of the urethra was
Was
also
also absolutely.
gone, and there was still a VVF, RVF, everything was there, and whole of the vagina was
Was
also
closed,
still
yeah.
35 years old.
Yeah, this was, yeah, madam has referred this case. I often tell her. So
And nothing was done for
probably
her.
the lady did not need hysterectomy, unnecessary hysterectomy
Yeah.
done. And then the patient had both VVF and RVF, and the doctor then what the doctor did, just close the vagina
Whole
and
of it.
everything, thinking
Yeah.
that if it will be
And
closed,
she was
but
just 35. But
fluid, yeah,
at the age of
yeah,
32, she had, for no reason,
yeah.
vaginal hysterectomy. She went with probably a decubitus ulcer and prolapse, and the same day they operated her, and then she developed VVF, RVF, and then what happened?
Yeah, so this is really very I mean, important. We have to take care of our
She
patients.
continued again
Don't be
for
in a rush to
follow up.
operate upon them. Carefully, like take history, taking examination, find out the cause. Like I did this patient, admitted her a week in advance. We did all the tests for her, showed her to cardiologist, nephrologist, and all that, and then only offer surgery. We keep getting surgery. I mean, I can give name also. Professor, our own HOD of ophthalmology, just retired, sir. He Padma awardee, treated Narendra Modi and all other operated. So his own mother, he brought to me. Auntie had some cystoscopy little bit, and but she has severe cardiac disease. So I was shown that patient by Dr. So I saw very mild cystoscopy. So he said, if you want, you can operate upon her. She had cardiac issue. I said, no, sir, not needed. If she was my mother, I wouldn't operate upon her. And within 3 months, she died of cardiac issues. So had I done operation for that mild cystoscopy, I would have been blamed that you did that. So you have to be very careful. We do surgery. I have done recently surgery on one patient. She was grandmother of one of our faculty colleague, and she came to me, 85-year-old madam. The first thing she said, Dr. Sharma, please मुझे जहर का injection लगा दो. So she had grade 4 prosidentia madam with 20 ulcers everywhere. And so she said, I just want to die. Nobody is giving me poison. So I admit, and she was not at history of DVT risk. She had DVT in advance. She had DVT in the leg, obese. So I admitted her for 2 weeks. So I told her grandson that you admit her in your ward now, and then I shifted her to my ward. So we gave her all drugs and all, ultimately treated her. Now she is totally fine. Another mother of our own pulmonary physician, she had this atrial fibrillation history and all. So again, she had third degree prolapse. I operated upon her to automatically her fibrillation came back after this thing. But we knew, and cardiologist, so we treated her and they are fine. So we do the surgery on those who are genuine cases where surgery is definitely required. We do it. Another this wife of chief, High Court Justice wife, 125 kg, 85-year-old, ex this thing, and her daughter also a Supreme Court lawyer. No, everyone is scared of these lawyers, and her daughter is a gynecologist consultant gynae in Canada. Son-in-law is consultant intervention. I said, why don't you take her there in Canada and operate? And I think just to please me, she has said, no, they're not a better surgeon than you in Canada. And he operated upon her, and luckily everything went on fine. Her table was small for her. The needle, spinal needle was small for her. We had to arrange a special this thing. Ultimately, everything is fine. But I mean, if things could go wrong, no, then I mean, they don't give you credit, but then but ultimately, like all these patients are fine, but they actually genuinely needed surgery. We admitted them a week in advance, did all surgery, showed them to cardiologist, neurologist, and this our anesthetist in advance, and then they properly fixed them. Don't be in a hurry or rush to operate on them. So then genuine cases you must operate, but I mean unnecessary surgeries must be avoided. I mean in Haryana also the patients are being operated for vaginitis. I mean vaginal discharge hysterectomy is being done, and they say cancer will develop. So anyone I think is scared of cancer. So this is unnecessary hysterectomy. We get patient from Bihar, Madam Dr. Seema, almost every week or every alternate week. Patient of VVF, 28-year-old, got married at 23 children by 25, 26, and 27 pay hysterectomy with big VVF. So I mean, and probably hysterectomy not even indicated. So so unnecessary surgery must be avoided. But I mean, my this thing to all of you, please, if you have your grandmother, on either side, if they have issues, so many times 80-90% without surgery they can be helped, they can be treated. So just like they are leaking urine is not a natural age phenomena. We can really help them by simple medical treatment, simple this thing. Okay, here you can show to ma'am, Dr. Seema, or or us, or you can refer to Delhi also. So we can really help them. So thank you very much. Thank you. Thank you.
What your friend from Canada said that you all are better surgeon is the fact. Indian
Okay.
urogynecologists
Okay.
are
Thank
a better surgeon than anywhere else
you. Okay.
in the
Thank you,
world.
madam. Thank you. Thank you. Yeah, probably we do
That's
so
a
much of
fact.
surgery. Yeah. Thank you. Thank you. Okay.
Thank you so much, sir, for breaking down urogynecology for us. Such complex concepts seem so clear when faculty like you come here to explain things to the students. Thank you so much. I would now request uh, our international faculty, Dr. Afsha ma'am, to felicitate Dr. J.B. Sharma, sir. And I would also request
So
Professor
Dr.
Seema.
Sharma, Indian Urogyne Society is there, na? So make her also a member of that society. Even we are not the member. So here you can make a membership drive that those who are interested, at least they should become the member. और कोई डायरेक्टर नहीं क्या?
मैम मैं भी आ जा रही हूँ